Order.
The Draft Human Medicines Amendment Regulations 2026.
I call the Minister to move the motion.
Ms Harris, it is a pleasure to serve under your chairmanship. I beg to move that the committee has considered the Draft Human Medicines Amendment Regulations 2026. In response to the COVID-19 pandemic, multiple temporary amendments were made to the Human Medicines Regulations 2012 in autumn 2020 to enable the rollout of the COVID-19 and influenza vaccination programmes. These amendments were extended in 2022 and 2024 following public consultation and are due to lapse on 1st of April 2026. This instrument looks to retain several provisions within those regulations as permanent legislation and expand them to other vaccines. It is designed to build upon the benefits that the amendments have provided to date, as well as wider lessons learned during the pandemic and in recent polio and MMR vaccine catch-up programmes. This will support the safe supply, distribution and administration of a wider group of vaccines, helping the ongoing development of a vaccination system that is fit for the future. I will briefly set out what each of these regulations does. Regulation 3A, paragraphs 1 and 2, enables trained healthcare professionals or staff under the supervision of trained healthcare professionals to conduct the final stage of assembly and preparation of COVID-19 vaccines without additional marketing authorisations or a manufacturer's licence being required. This enables bulk assembly of COVID-19 vaccines during the pandemic. Given the more targeted approach of recent COVID-19 vaccination campaigns, this instrument allows these provisions, 3A, paragraphs 1 and 2, to lapse from the 1st of April this year. Regulation 3A, paragraphs 3 and 4, permits holders of a wholesale dealer's licence who do not hold a manufacturer's licence to relabel COVID-19 vaccines to reflect changes in shelf life resulting from product thawing. This instrument retains these provisions as permanent legislation and expands them to include any vaccine against any infectious disease. This will enable a more efficient use of the capable vaccinator workforce and supports further flexibilities in our supply chain. Regulation 19 allows COVID-19 and influenza vaccines to be moved between different NHS service providers at the end of the supply chain without the need for a wholesale dealer's licence. This instrument retains these provisions as permanent legislation and expands them to include any vaccine against any infectious disease with relevant safeguards to regulate its use. This will ensure vaccines can be rapidly deployed in exceptional circumstances in response to public health needs. Regulation 247A enables the use of an extended workforce who are legally and safely able to administer COVID-19 or influenza vaccines without the input of a prescriber using an approved protocol. This instrument allows Regulation 247A to lapse from 1st April 26 and introduces a new permanent provision, Regulation 235A, to continue the use of an extended vaccinator workforce through the introduction of a vaccine group direction. This will support the use of an extended workforce to administer any vaccine against any infectious disease where directed by a national body and will ensure the UK has the necessary agility and flexibility in its workforce to deliver those vaccinations. Regulation 233 enables persons lawfully conducting a retail pharmacy business to deliver COVID-19 and influenza vaccination services off the registered premises under this patient group direction. This instrument expands this provision to include any vaccine against an infectious disease. Additionally, Madam Chair, to enable these services to continue after Regulation 3, paragraphs 1 and 2 lapse on 1st April this year, this instrument amends Regulation 3 to enable pharmacists to prepare or assemble medicines for a patient in the course of their treatment without a manufacturer's licence. This will ensure that community pharmacies can deliver vaccination services off their registered premises, enabling them to deliver targeted outreach programmes. Schedule 17 introduced a category of occupational health vaccinators who are permitted under the written directions of a doctor to administer COVID-19 and influenza vaccines as part of an NHS or local authority occupational health scheme. This instrument amends the list of professionals able to deliver OHS vaccinations to align with the professionals able to supply medicines under a patient group direction. In addition, this instrument expands the scope of Schedule 17 to cover any vaccination or immunisation offered as part of an OHS. These changes will improve access to vaccines for staff within and beyond the health and social care sector, protecting them in the vital roles they do. In developing this SI, this government conducted a public consultation from 5th September to 28th November 2025 on its proposals to amend the Human Medicines Regulations. This consultation was hosted by the Department of Health and Social Care in relation to England, Wales and Scotland, and acted jointly with the Department of Health in Northern Ireland. Medicines regulation is a transferred matter in relation to Northern Ireland and a reserved matter to the UK Parliament in relation to Scotland and Wales. 218 responses from organisations and individuals were received, sharing professional and personal views. Overall, the majority of responses were supportive of the proposals set out in the consultation. We received many positive comments on how the flexibilities within the regulations have helped to increase access and efficiency across the system, whilst effectively utilising the workforce that has already come into place since the COVID-19 pandemic to deliver COVID-19 and influenza vaccinations. The consultation posed 15 questions on the technical aspects of the regulations and saw broad agreement on each of those proposals. Given the technical nature of the questions and the limited time to talk on these, I suggest I do not provide a detailed analysis on each response here, but they can be accessed the published government response can be accessed on the gov.uk website. Building on the successes of the large-scale vaccination programmes during the COVID-19 pandemic, this instrument will support patient safety, improve access and availability of vaccines, and ensure the vaccination system continues to innovate. The amendments will implement improvements which will help facilitate the shift from sickness to prevention as described in the government's 10-year health plan, helping to restore trust in vaccinations and ultimately increasing vaccine uptake. Regulations 233 and 3 will also enable community pharmacies to play a bigger role in prevention through expanding their role in vaccine delivery and enabling targeted outreach to support areas where health inequalities are still pervasive and where evidence indicates this is clinically appropriate and value for money. The amendments will also support delivery of commitments in vaccination and immunisation frameworks in Scotland and Wales. An instrument is being laid in parallel in the Northern Ireland Assembly to deliver changes to the vaccination system across the United Kingdom. To conclude, Madam Chair, this instrument makes amendments to permanently support the safe supply, distribution and administration of a wider range of vaccines. These proposals were supported by the majority of respondents to our consultation. I therefore commend the regulations to the committee and hope that honourable members will join me in supporting them.
The question is that the committee has considered the draft Human Medicines Amendment Regulations 2026. Dr. Caroline Johnson.
Thank you, Madam Chair. Pleasure to serve with the Chairmanship. Good morning. We do not intend to divide the House on this regulation, and anything that improves trust in medicines and vaccines is important. We do need to increase the uptake. The uptake has fallen sort of gradually over some time, and it continues to fall now. We do need to do something to reverse that. So a couple of technical questions. On the amendment of Regulation 3, the principle of it, as the Minister has said, is to make prescribing to pharmacists equivalent essentially to doctors and dentists in this regard. But as a minor point, the original regs in paragraph 8 refers to another doctor or dentist in the same practice. Since it will now include doctors, dentists and pharmacists, should it say another doctor, dentist or pharmacist, or should it say a doctor or dentist? So just a technical question really. The amendment of Regulation 8 redefines an occupational health vaccinator and gives a list defined in Part 4 of Schedule 16. It's a significantly broadened list and includes individuals such as speech and language therapists who are not accustomed to dealing with injectable medications. But it appears to now to exclude ODPs who are very used, as the Minister will be aware from his own practice, to dealing with injectable medications. I wondered if you could explain the reason for removing them from what was the original list. And then clauses 8 and 9 talk about the vaccine group direction. So the patient group direction is essentially a group prescription, Madam Chair, where a clinician signs off the circumstances in which a medication such as, say, paracetamol may be given by a non-prescriber. And we had those during the pandemic for the COVID vaccine. This would be a vaccine group direction which is different. I wonder why he feels that you need a different type of process to the patient group directive that's already available for vaccines which are prescription medicines. But this can be signed by a manager who's not a clinician. So it can be signed centrally by a manager in the Department of Health or in a company, in fact, private company, in fact. But it doesn't need to have any clinical skills or qualifications at all. And then can be given, then it's then required for a clinician or one of the people listed in that previous list that I described to decide whether the conditions are met, and then to give the patient the medicine without having prescribed it. So I just asked a couple of questions with regard to that. How does that improve trust when we've got a vaccine skeptic population and lots of material on social media, some of which is not entirely accurate? How does allowing a prescription that's originally written to be written by someone with no clinical experience actually help that trust and help those rates? Is there a plan to contract out vaccine provision to the private sector, because that's what this allows for? And how does the who is responsible ultimately? Is the person responsible ultimately the person who signs the vaccine group directive, who's the non-clinician? Who is the ultimate clinician responsible for the decision making to give the vaccine in the event that someone has an allergic reaction to the vaccine or an adverse reaction of some other type? Thank you, Madam Chair.
Minister.
I'm grateful to the Honourable Lady for her support. She is a learned member of this House, and I know she takes these matters extremely seriously here and also in her own clinical practice. To address some of her points, from the technical point that she raises, I'm very happy to explore that to ensure that the wording is optimal, indeed whether it should involve the word pharmacist or not, given the updating of the regulations. In terms of workforce, I'd just like to reassure her that in terms of the workforce that we're talking about, there will be training and a governance framework set up by the UK HSA who will oversee all of this. So whether it's in an ODP or anyone else, there will be a basal level of training that we can all be reassured by, both as members of this House, whether one is a clinician prescribing the vaccination or indeed a patient or a citizen receiving it. And that will be seen very tightly, overseen tightly by the UK Health Security Agency. In relation to her question on vaccine group direction versus patient.
Before he goes on to that, could I just ask him about why ODPs appear to have been removed from the list?
I'm not clear as to why they've been removed from the list, but certainly my expectation would be that anyone who is reasonably trained would be able to deliver vaccines in the setting that we are proposing them to be delivered in, which is community, hospitals, and everything everywhere else in between when we need to think about hard to reach communities. In relation to her question on vaccine group direction versus patient group direction, the primary difference is the VGD allows for the separation of the decision to treat by a registered healthcare professional, which still needs to exist, and to provide the consent in that situation from the administration of the vaccine, which is then done by a separate individual. This is not permissible under the PGD. It's a separation of roles, but I'd like to reassure her, of course, the consent process, the prescription process is paramount, and she is right, it needs to be paramount to continue to have, for people to have confidence and for us to imbibe confidence in the process of vaccination. Madam Chair, as I set out at the start of this debate, these...
Sorry to interrupt, but we're Minister away. I thank the Minister for giving away. He's been very generous at this time. Can he confirm, though, that the vaccine group directive, and unlike a patient group directive, which would ultimately have been signed by a clinician, that this would not need to be signed by a clinician, it can be signed by a senior manager, either within a company or within a department?
Dr. Ahmed.
So I will clarify that for her, but the wider premise here, and the wider point I think we're both cognizant of, is the fact that clinicians ultimately take responsibility for prescriptions and for informed consent of a vaccination process. That will still continue. Healthcare professionals will still be providing and seeking consent for treatment. The VGD simply means that person can be separate to the person then administering the vaccine in practice. So there's no suggestion that there's not going to be clinical oversight or governance of this process. Quite the opposite. This is to tighten governance frameworks and make them more transparent. As I set out at the start of this debate, Madam Chair, these amendments aim to support the ongoing development of a vaccination system that is fit for the future. The proposed amendments are designed to build upon the benefits that HMRs have provided to date, as well as wider lessons learned during the pandemic, including recent polio and MMR catch-up programmes. In amending these regulations, the Government is seeking to maintain important safety measures while also increasing the effectiveness of the system's supply chain and workforce when it relates to vaccination and vaccination programmes. After clean water, Madam Chair, the science is unequivocal in telling us that the vaccination is the most effective public health intervention in the world for saving lives and promoting good health. It is therefore a solemn duty of this government that it do all it can in this space to support the health system's ability to deliver vaccines for all those eligible and, in turn, help support vaccine uptake. Given the overall support of the proposals in the consultation and the ongoing need to support the continued safe and effective supply, distribution and administration of vaccines both now and in the future, it is the intention to make permanent the provisions discussed during this debate. I commend the regulations to the committee.
The question is that the committee has considered the draft Human Medicines Amendment Regulations 2026. Has many of that opinion say aye? Aye. Of the contrary, no. I think the ayes have it. The ayes have it. Order, order.